All right, so I'm going to go ahead and get started. Hi, everyone. My name is Alexis Sanchez. I'm your facilitator today. I'm the assistant program manager at the Institute for Public Strategies. I work on our West Hollywood project, which focuses on methamphetamine use primarily, and then binge drinking in the LGBT community. I have with us this really incredible panelists. These incredible panelists. Everyone here is so cool, and I'm really excited to hear from all of you. We're going to be talking about harm reduction during a pandemic. For those who aren't familiar, harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. Harm reduction incorporates a spectrum of strategies from safer use to managed use, to abstinence, to meet drug users where they're at, addressing conditions of use along with use itself. Because harm reduction demands that interventions and policies designed to serve drug users reflect specific individual and community needs, there's no universal definition or formula for implementing harm reduction. We're just really about meeting and helping people where they're at, and I think that is one of the most honest and amazing things that a person can do. So I'm going to go ahead and start introducing, or I'm going to let our panelists introduce themselves. I'm just going to start clockwise on my screen. So Amanda, would you mind introducing yourself?
I was hoping I was going to go last. Hi, I'm Amanda Cowan. I'm excited to be on this. Sometimes harm reduction is considered a dirty word, so I'm really excited to have a conversation and kind of discuss what that looks like in practice. My background is social work and sociology. I have a master's in addiction and mental health, and then I dropped out of a PhD program working on health equity. So I really love the discussion of the intersection of restorative justice and drug user autonomy. I work for an agency called Claire Matrix. We hold the grant for the state targeted response for the opioid epidemic. And what that includes is kind of overseeing funding of federally qualified health centers, making sure that folks have access to medication-assisted treatment, so the 3 FDA-approved medications, and that includes picking up the cost for anybody that's uninsured or underinsured or some public charge, et cetera. Part of that includes working on policy and well, I know we're going to get into that a little bit later, so kind of discussing policy around drug use and California laws. And then the biggest part of my job is working on trainings around stigma, first-person language, and naloxone distribution within the community. You're muted, Alexis.
Rookie mistake. Next we have Roger Seviles.
Yes, my name is Roger Seviles. I work for APLA Health, and I run a program based on harm reduction. It's a program that aims to reduce the risk of transmitting or acquiring HIV and STDs. At the same time, we work with clients to give them information on just straightforward strategies to reduce the harm related to their drug use. We refer them to needle exchange, to mental health services, food banks, different services, whatever they need. So it's a very practical program. At the same time, we make sure that people that are out of care, even if they are using any drugs, that they go back into care for HIV. A lot of times our clients think that because they are using some kind of drug, they shouldn't, or they should stop using their meth for HIV. So that's one of the biggest thing for us. And I've been working there since 2007, and we also do different things. We do outreach, we do groups, we also have a clinic that we make sure the clients have healthcare as well. And so I think that's what I can share about me. Thank you.
Great, thank you. Next we have Tobin Shelton.
Hi. My name is Tobin. I work at the Venice Family Clinic. I am a psychotherapist there, but I also supervise a program called Summit, and Summit is a program that provides medications to folks to support their recovery. If that's a good fit for them, we do buprenorphine and Vivitrol. The Venice Family Clinic is pretty big though, and we're on the west side, and we have lots of different things going on there. We have about 30,000 patients that come each year, and we have a syringe exchange that's co-located with our medical services, and that's at 622 Rose Avenue in Venice. We also do walk-in testing for Hep C, HIV, and STIs, and we do a lot of primary care services there. And I'm excited to talk about what COVID has meant for our clinic as a whole, and then kind of personally for my work as a clinician and supervisor. So glad to be here.
Great, thank you so much. Next we have Jesse Goldshire.
Hey everybody, really excited to be here. The other panelists, we were talking the other day and I just got even more excited. My cat is deciding to make an appearance. So I'm a doctoral student at USC in the Department of Preventive Medicine at Keck. My work mainly focuses on drug use and harm reduction, but I also do a lot of work in the realms of LGBT population. Specifically, I'm doing a little bit of work right now with sexual minority men and drug use among that population. I've been working with syringe exchanges since I started my master's degree on the East Coast in Philadelphia, and transitioned that work out here to do work with my mentor, Ricky Blumenthal. Yeah, I think that's about it.
Great, thank you. And then finally, we have Amber Roth.
Hi, good afternoon, everyone. My name is Amber, and I work with Homeless Healthcare Los Angeles. I'm their Director of Operations and Programs, and I've been with the agency for 8 years. We really pride ourselves in working with the most vulnerable and hardest to reach populations, pretty much throughout Los Angeles County, but our service area that we really hone in on is Service Plan Area 4. We do a variety of different services from behavioral health. We have an outpatient substance use treatment program that is very unique because it serves clients that are actively using substances to those that are on their journey to abstinence. We also have a lot of street outreach teams, medical outreach teams, and our housing programs. We do support clients from not only when they're currently living on the streets, but also transitioning into permanent housing, and then do a lot of retention work to ensure that they maintain their housing. We have a very unique site in Skid Row called the Center for Harm Reduction, which is where we do our harm reduction wellness program out of. After post-COVID, I guess, we started it right before COVID hit, and then that kind of got put on hold. We do syringe exchange and naloxone distribution. We have medical services, wound care, our medication-assisted treatment programs out of that site. And I'm going to talk a little bit more about this in a moment, but we also launched a new peer-led outreach COVID team that our clients actually have taken lead in developing as a part of our efforts to address COVID. And then the other key program we have in Skid Row is our Refresh Spots Center, which is an outdoor hygiene facility that really just provides basic access to clean restrooms, showers, and laundry facility. And it's a really nice way to just provide dignity back to individuals living on the street. So, and then last but not least, we do training and education. So over a year, we serve around 26,000 unduplicated individuals, and just really make sure that everyone feels that they have a purpose and that they're wanted. So excited to be here.
I'm so incredibly excited to have all of you. Everyone does such incredible work. So some of you touched on this in your initial introductions, but I really wanted to hear how has your work changed since the Safer at Home ordinances were put in place, since we started having to wear PPE? I know I've heard from a lot of community members that the people who are doing homeless outreach all of a sudden can't have those face-to-face interactions that they were using to liaise people into treatment and services. So how have you adjusted kind of like your workflow and your services to meet this pandemic?
I'm happy to start. So a couple changes have happened, most of which have been pretty major. So the first big change that occurred was that we suspended almost all of our research field work. So any of our in-person work where we are recruiting participants for our studies, we do community engaged research. So we're always out in the field working with stakeholders, interviewing people, surveying people, working at the organizations that we work with, which is really important to us. And unfortunately, you know, we can't be out in the field, at least right now, for the foreseeable future. And so that's really put a hold on some of our critical research work that we were doing. Additionally, personally, I was working with CHPLA's Syringe Exchange twice a week in West Hollywood. And because of the limitations of social distancing, they really had to change their operations to suit both their full-time workers and their clients for safety purposes. And so because of that, both myself and several of the other volunteers, you know, we didn't really fit into that equation in terms of making sure that both the full-time staff and the clients were protected as well as they could be. And so kind of on both fronts, both the kind of community service end and the research end, a lot of the projects that I've been working on are kind of on hold for the minute, which has been tough, both for me personally because I enjoy it, but also our participant populations who are kind of expecting us to be out in the field interacting with them on a weekly basis.
I think I can go next. I think for us, the APLA Health Prevention Department, which is where I work within the prevention department, just like most agencies had to make adjustments to the way services are usually provided so that we'd be able to assist clients. We're making sure that all former and current participants can reach out to our different programs. Currently, there are a number of live videos, just like this one, facilitated by many of our prevention department great team members, making sure that we keep having conversations that are meaningful and that are needed by the community we serve. We're providing clients with different referrals as needed. We're making sure that people who are symptoms for STDs or that they are linking to services as well. And those who are not in medical care for HIV, also that are receiving HIV care. But yeah, so we definitely had to and have to and continue trying to you know, reinvent the wheel and figure out different ways to serve the community. And that's we make sure that we call our clients to the clients that we had before, like, that participated and completed our program, and just to kind of like figure it out, what is it that the people need right now at the moment. And so that's what we are doing right now.
I can go next. This is Amber with Homeless Healthcare. So I think when this all first began, one of the biggest things that we were really grateful for was that we were considered an essential service provider. And so I really feel that the team jumped into figuring out, okay, it's not about what we can't do during this time. It's about how do we continue to do what we're doing, but just look at it, how do we do this differently? I think the biggest thing that all of us, I can say, really thought about was like, we don't want our clients to feel abandoned again, because usually what happens in times, everyone runs and tries to take care of themselves, and people that have resources and, you know, have access to things a lot quicker, our clients don't. So we immediately thought about how do we make sure that our clients do not feel abandoned during this time, and when like the stay-at-home orders go into place, and for our clients that don't have homes, what does that do? You know, it just re-traumatizes again. So we really focused on that, while still maintaining a lot of the precautionary measures, you know, social distancing, making sure our staff have PPE, our clients get PPE, so that way we can continue to deliver services. So just so I don't take up too much time, a couple of key things that we did roll out a remote. We first kind of looked at our services, at what do we want to make sure that we can continue to do, what are like high risk services that are very crucial to keeping people alive. on site, which that included our refresh spot and our syringe exchange services. So those 2 locations have not stopped operating since this started. And then we looked at another kind of like the second layer, which is our outreach services. We do have outreach team members that were willing to still go out into the field. We purchased a lot of different resources to help clients build their immune systems. We, purchased tents for our clients that were living outside and didn't have a tent. So just being creative in that way, care kits, things like that. And so our outreach team members were really instrumental in getting those things distributed to not only our clients, but just the clients living in the communities that we serve. And then also our street medicine, we have a couple of physicians, which I'm sure a lot of you have heard of, Dr. Susan Partovi. She's been very instrumental during this time in not only doing medical services. We recently started doing COVID testing out in the community for the clients we serve. And then we did also implement for our behavioral health services and housing services. We've actually still housed over 30 people during this time. We've been doing a lot of like interim housing placements. Most of that is being done either remotely, telecommuting, and also the telehealth platform. But like I mentioned, one of the key things that we really were excited about that we were working on implementing, and it just kind of pushed us to do so, was this peer-led COVID emergency outreach team in Skid Row. And what that really has done is it's clients that are taking the initiative. We actually are giving clients, paying them stipends to do this work. So they're getting money during this time. And they're going out, they're distributing the lock zone. They're talking to our staff, letting us know where the shooting galleries are at, where people are overdosing more, because overdoses have gone up tremendously during this time. And they're educating their neighbors, right, to be able to be safer during this time. And our clients even were taught ways and tips to stay safe during COVID while living on the street. So they actually have been one of our highlights that we, just really appreciate their educating us as we're trying to educate them to help others. And so that's been a very successful intervention that we've done as well.
I can go next. So the clinic kind of as a whole, we have about 25% of folks working from home, folks who were at higher risks themselves or needed to attend to their children or home lives were able to go home and do that. The clinic's response was to sort of be, I think, cautious at first. We work under the UCLA umbrella, so we sort of follow the guidance of UCLA. But some of the things that happened more specifically related to the services for folks who use alcohol and other drugs have been really cool. So we have about 450 people who take medications for opioid dependence regularly. And we used to have groups where people would come twice a week. Really about 15 or 20 people would come in a group, have like a psychotherapy session with the doctor in the room, and an hour and 15 minutes later, everyone would leave with their medicine. Those obviously are not happening. They were the first thing to go. And so the providers are actually kind of keeping those folks in the same time window and making a lot of phone calls, prescribing to pharmacies that are more local for the folks who are getting the medicine. And that's a huge range. I mean, it's Pico Rivera, it's all sorts of places around LA. Sometimes people were coming 2.5 hours on a bus to get their meds, and now they're speaking with the doctor one-on-one. And the providers have been really cool about adjusting to that. And folks have been a little nervous, I think. We've had some struggles with pharmacies that are not used to doing this kind of dispensing. Most folks usually get the medications at our pharmacy. So that was a huge shift just in terms of medicine. And then the non-medical, the more behavioral health and case management stuff that we've been doing, all of my staff is at home. A lot of the adjustment that was around it was based on sort of like the spectrum of safer and less safe, which is a spectrum that we're used to in harm reduction. And sort of moderating our own sense of urgency as the sense of urgency around us is what it is. And so a lot of the really interesting work that's happened is sort of around struggle and like a trauma response to something that is traumatic, but then also kind of watching people really be able to kind of acknowledge that, harness what they can. We're actually more like productive during this time. We're home making phone calls and connecting with our participants all day. And telehealth has allowed for this really neat thing, which is that if I call somebody for a 4:15 appointment and they don't pick up, I can leave a message and say, hey, I want to connect with you today. What I'm going to do is wait 5 minutes. If we don't talk, I'm going to call someone else and we can talk again later. So if I miss somebody, then I can go right to the next person and like really keep the community cohesion that way, letting people know that I'm thinking of them, that we want to connect, and that maybe next time. So it's been a really nice way to actually stay connected. And I think later we'll talk about the future, but there's a little plug for the future, is being able to do more of that. So, yeah. Oh, one last thing. The syringe access basically is the same as well, right? And naloxone distribution, our street medicine teams are also going out. A lot of that is basically unchanged. Yeah.
Okay, I will try to be very short and brief after those, really great examples. I guess I wanted to say the one really positive thing about the harm reduction movement generally is I think we have always worked being severely underfunded and with very, very limited resources. So the fantastic thing about this community is that we were all able to pivot incredibly fast. And I think it's something that we kind of took on and did, which has been great. But from an administrative perspective, the things that were lost, unfortunately, were kind of certain grants that were really exciting and we're looking at starting up. There was a really incredible project that was supposed to be starting up on Skid Row around medication-assisted treatment, kind of being prescribed on the street. That got pulled. So there are a lot of different kind of exciting, how Jesse was referencing kind of like research-based that unfortunately had to stop. What's been really interesting is the telehealth switch, like Tobin said. Traditionally, telehealth was a luxury for those that had private insurance. And it wasn't really something that on the provider end, the pay scale, unfortunately, for telehealth is not great. So a lot of people didn't want to invest in telehealth and didn't want to use telehealth. And I think it's been an incredible push. The government has actually done a complete shift. They've, restructured the pay system. They've taken away a lot of the restrictions that were there around like the two-way communication around a video and the phone content. So now we can start BUP a lot easier. Methadone take-homes are a lot longer. So there's been some really fantastic changes. And I know, we'll talk about future and what we see later. So there's been some really fantastic changes that have happened overnight. I think the thing is that we are just learning day by day. And I know in the beginning, it was kind of what Tobin said about us learning to regulate our own emotions too, because it was, we're inundated with information and we're dealing with very marginalized, vulnerable populations that we want to make sure that we don't re-traumatize or we don't cause any more harm. And so what we had kind of discussed about things being taken away on the street, we had to go and very quickly turn around. How do you do naloxone while COVID is around? How do you, change rescue breathing to hands-only compressions? So those little twists that had to be modified very, very fast. So I think we were all working, all of us on this call, I'm sure we're all up hours of the night, every night for the first couple of weeks of this, trying to suss out all the information and how it actually works for our participants. And then lastly, kind of, working goes back to Matt and the expansion. It's been really exciting, like with Project Room Key and getting people off the streets and moving people into isolation sites, looking at how we can expand MAT access. So I know I'm speaking from more an administrative level, but that's kind of the changes that I've seen that have been pretty drastic since COVID began.
I love the breadth of experience, like there's people working in different sectors and people working in policy and people working in street outreach and everything in between. And I think that this panel has a really, really great perspective when it comes to that. Some of you have started talking about the future, so let's kind of move there. My next question I wanted to ask, it's kind of a two-parter, right? I wanted to think through, and we've already mentioned some of these things, but what do you think will stay moving forward? What are some of the best practices that we've developed? We've already mentioned how telehealth is kind of here to stay. There are policies that are being worked on that, could have a benefit, but there was always a little bit of reluctance. And now in the face of a pandemic, like there's more political will behind that. So what do you think some of the positive changes will be moving forward? Or what are some of the things that you hope that we will really keep when, this pandemic kind of fizzles out, hopefully?
I'll jump in really quickly. Just continuing on my last point, I hope that telehealth stays. I do have concerns around telehealth. I don't want it to suddenly completely negate the idea of having face-to-face interactions. I think we will always have participants that fare better being able to go into a clinic. That's my only concern, is are we going to potentially move so far the other way that then we start stopping some of the really important services. At first, it stopped a lot of the policy work in its tracks that I do, but I have to say it's been a really great momentum. I think, sadly, unfortunately, the whole country has kind of shined a really big light on health equity or lack of health equity and access to healthcare. And so I think more and more people are engaged and interested in what we're doing and want to see a shift. And there's more buy-in in some of the stuff that might have seemed more outlandish or hard for people to understand when you kind of first approached it with them. So with the DEA loosened restrictions, we hope that those stay because it just creates less barriers for our participants. There are so many reasons why we want people to be on longer term and have longer access to medications. It just doesn't disrupt their life in the same way. It's really fantastic to see the regulation of not needing a first face-to-face appointment with a provider, because again, that creates a lot of problems. Tobin's, discussing somebody that travels 2.5 hours each way. That is a huge disruption to normal life. So that's a concern, that's something that would be really great to see. In terms of some of the policy that's been really exciting is was working on getting an overdose prevention site folded into the bill for the rest of California for Los Angeles County. And that work was kind of paused for a little bit and it's starting to pick up momentum again. So that's really exciting. I think people are really starting to grasp the intersection of all of this and how everything's kind of merged, and it's almost a syndemic at this stage of just everything that's happening and piled on top of each other. And so excitement for overdose prevention sites have really gone up. I work on the west side. It can be traditionally a little bit more conservative when it comes to allowing for kind of new innovations. A sobering center was shot down a few years ago, right? We had all the plans in motion to kind of have it in Santa Monica, and then it was shot down. And now conversation is coming back up about a sobering center because we want to have all of these modalities. We're so aware of how important it is to get people off the street and get them into safer spaces. And so I think that's kind of been something that's really been great, and I hope fuels more momentum moving forward.
So as someone who's been kind of highly focused on community-based and community-engaged work for probably the last 5 or 6 years or so, one of the things that from the beginning was always highlighted to me as a researcher was that harm reduction is first and foremost a community-based effort that kind of comes from the ground up. And it comes from the people that harm reduction groups serve, who were kind of the originators of these organizations. And one of the things that I've personally been kind of the most worried about moving forward is this idea that harm reduction spaces might no longer necessarily be a safe place for community members to kind of meet and chill and hang out and discuss what their lives are like. And I think that's one of the things that, syringe exchanges have always been great at, is this idea that people can show up, we meet them where they're at, and they don't have to be anybody but themselves when they come to the needle exchange. And on the flip side, they see a lot of people they know there. It's a communal space. But now, in the face of, like Amanda said, this syndemic situation, we've kind of, at least in some respects, started to limit that ability of people to congregate, right? And I guess part of me is worried that when things go back to normal, if, whatever that normalcy may be, if we don't find a way to enable that type of kind of close community interaction and almost like a safe space for community members, that could potentially have a pretty negative effect on both harm reduction efforts, but also on the health of the people that those harm reduction efforts are kind of meant to serve. And so I know the question was originally about positive things moving forward, but I do think that it's important to highlight this idea that we might need to find ways to work at reestablishing those kind of community safe spaces for people to feel at home and to feel like they aren't being judged like they are in every other aspect of their lives on the streets.
I think I can go next. Just to piggyback a little bit of that. In the conversations that we've been having with clients, this is one of their main concerns, right? The fact that they are not able to congregate and to see their peers, their friends, people that they know from out there, from groups, from whatever, they are experiencing, depression and ways that they didn't before. And isolation was part of some of their lives, and so that was the only place that they had to talk about their lives and whatever it is that they need and they want to work on, or they don't want to work on, they just want to share. And so one of the things that we're looking at now, and obviously it's not going to be the same, but at least to bring something for them that they can utilize during this time, and maybe even after, whatever that means, normal is back, right? I think that this is going to be the new normal in a way, at least for a while. And so one of the things we're doing is that we're working on we pretty much done. We created a group that we're gonna have online with mental health providers or other guests that can talk about different topics with clients. Obviously, that's not gonna alleviate the part of the sense of community where everybody congregates and together, but at least can give them the sense that they've been part of something, right? And we keep finding out what are the best ways from them to service them. And so that's one of the things that we are currently working within the PartyWise program with clients. And so, I just wanted to share that.
I just kind of to both of those points, I guess, I think that it is important, definitely, that we maintain the safe spaces that we've all been able to create at all of our agency. That is like the heart of what harm reduction is. But I do think that with what happened with COVID, because things had to change so rapidly, one of the key components of harm reduction and looking at programming, at least, and administering and developing programming, is really reducing the barriers and creating low thresholds. And I think in the beginning, I know when we were talking about having to put certain mechanisms in place, like social distancing and putting up almost barriers, we were like, we're going backwards in time. But now I feel that, now that things are we've gotten kind of used to it, we've been able to look at things and be even more creative in how we're approaching this, where we're getting back to, I don't want to say we're fully there, but back to more lower barrier type settings and rules, as we're still trying to be safe and help our clients to maintain safety. I do think that just across the board, though, like Amanda was highlighting, some of the regulations with MAT have gotten loosened up. Some of the HIPAA regulations that, from working in the mental health and substance use arena have definitely been looser a little bit, so that way we could do services over the phone or do different things through the telehealth platform. I think it's been an opportunity to really highlight that, especially substance use services, we've been really focused on as an agency, and I know some of our partners that want us, make sure that the full continuum of people who are actively using to those that are, again, possibly seeking some type of abstinence, that they're all being served. And I feel like our people that are actively using right now, we've been able to really hone in on that a little bit better with like focusing on the overdose prevention or the safer injection sites, and also just really advocating more that this particular population doesn't get left out. I know we've even been able to do some counseling services or just reach out and let people know, when you're ready to just be a part of something, we're here. And I think that's been nice about COVID. I know Tobin was mentioning about being able to stay connected better to our clients. A lot of the staff have reported that too, which has been great because there's been so much. So many clients have been isolating and the suicide rates have gone up, and we talked about substance use rates going up. So that time for connection, again, which is what harm reduction is all about, is creating those social bonds for people, is there. And I think we do have to continue as a group to figure out what's that going to look like as we continue to move forward. And then the last thing that I'll share that I felt was really positive on best practices is I feel that all bets were off. Like a lot of departments started working together, and I want to do a shout out to the Department of Health Services, medical staff, grassroots organizations who were not afraid to go out there. We're doing the hard work and distributing supplies to clients, and then as well as some of us community-based organizations, because let's be honest, there were some that shut down. Our clients, that was one of the biggest thing that our clients said, is that we can't get access to our resources. So a lot of our agencies, all that are on this call, stepped up to the plate, and we're like, no, we don't want to shut down. We want to figure this out. How do we keep providing those services? And I just am really excited that even at some of the COVID sites that DHS opened up, they were asking for they were giving people alcohol because they were starting to detox, and they realized that that wasn't helpful. That wasn't well for them. They were giving edibles on site. So I think that it's really helping us to think differently and looking at these interventions that we all believe to be so helpful, and we know that it's in the best interest of serving the clients that we serve, are really starting to be looked at as a normal type of practice or best practice now. And I think that's really a huge accomplishment, at least a better starting point to continue from than what we've had in a while.
So I have some of this is a little bit abstract because the future feels a little bit abstract. But then I have some really more concrete wishes. But I think that from this, I noticed health services and health service leadership thinking more in terms of relative risk and using language of relative risk in a way that I haven't really heard in the past. And I like that change. I think it helps to support people's health and the way that they view their health and their own bodies and their own sense of safety as they relate to the healthcare system. If the people in the system are saying, let's think through this, right? There's a real communication going on between the clinic and the patients of the clinic, wherever they're saying okay, let's talk through what it would be like for you to come here, and maybe what it might be like for you to take care of some of that on your own or with your family, and see how that goes, right? And sort of weigh that. The call center is now just become an ethicist, a decision tree support for the folks who call in. So that's really cool. And I also think that there's some trust that's implied when we talk about giving people take-homes that maybe would not have gotten take-homes, or someone calls in, the first time they get a 1 week of buprenorphine, the next time they get a month, because it's hey, sounds like it's going well. Sounds like you are where you need to be with the people who keep you safe. Let's just go with that, right? And there's a real trust, I think, implied in that. I'd like for the implied trust to be made explicit, and I think that happens somehow in a different way. It happens when we gather, probably, back into the group. And so hopefully we can gather and sort of talk about it explicitly, what that trust is and what that looks like. Because right now, the medical provider holds the power, right, in that dynamic. The other thing has to do with mutual aid, and just I feel like there's this nascent sense of mutual aid among people who have not thought about mutual aid in the past. Mutual aid just meaning the ability for communities to take care of themselves, and that there's lights being shined on that are new, and I don't understand them yet, but I have hope around them. The other one is around race and the carceral state, and there's now legit you can really just see it where like there's decisions about like how we've put people in cages in close proximity are being questioned because of like the immediacy and the urgency of the need to just not have people living in those kinds of conditions, because those conditions are terrible and no human should live in those conditions. But we're really like seeing it, and there's like an incremental decarceration happening in most states, in most counties, and I think that that's really promising. It's incremental, but I think it's promising. And yeah, I also have hope for my field, like my mental health field. There's been a strong sense of purpose around people who, like, I'm ready to talk for 10 hours a day and communicate with people for 10 hours a day about these issues, about like regulation and about safety and stuff. And so I have, there's like some juju there that's very personal for me.
Those are all really, I mean, this is great. And I love that, you know, like looking at these issues, we really have to look at them holistically, and looking at the intersection of criminal justice reform and access to housing. All these things play into substance abuse issues, overdose deaths. So looking at them holistically, I know that this pandemic is shining like a light on a lot of the issues we have, and it's uncomfortable, but hopefully that leads to some positive change. I wanted to acknowledge some of the people in the chat. As a heads up, after this webinar, there's an email that's going to go out. And in that is going to be a link to a Google Drive, which we've kind of put some of our resources in. There's a guide on like safer drug use during a pandemic, how to use naloxone safely, a map of the different Venice Family Clinic service sites. There's some pretty cool stuff, and I'm going to hope to update that. So you all should be getting that tomorrow. There's also my email, and you can follow up with any questions. And then I've been kind of tracking some of the better questions, and I'm going to ask those at the very end as well. But right now I wanted to get back to, you know, we started to talk about mutual aid, and to me, mutual aid and harm reduction, when you look at the history of harm reduction and how a lot of the modern syringe exchange movements came out of the HIV epidemic and kind of like communities coming together to help each other, there's a natural intersection. But I wonder if some of you could talk to that intersection of mutual aid and harm reduction and what's happening in communities now.
Sure. So I've been doing some work with mutual aid groups in the area, probably after about maybe 2 weeks in to the stay-at-home order really started to take effect. The main group that I've been doing some work with is Street Watch LA, but Street Watch also does work with Ground Game, which is another mutual aid group. And both groups are kind of broadly focused on vulnerable populations. Street Watch specifically does work with unhoused populations around the city. We have local chapters in pretty much every major neighborhood at this point. I myself am on the West Side team. We also have Koreatown. I think Mid-City has its own group. There's like 5 or 6 different Street Watch groups, and all of them have been working together to gather resources, gather funds, and kind of redistribute all of that through to the unhoused communities in our areas. So I live in Palms, Culver adjacent, and there are several fairly large camps right near me, and all of the mutual aid and service kind of grassroots groups have been really hitting the ground hard in my neighborhood and other West Side neighborhoods, trying to stay in contact with unhoused folks, both who use and who don't use, and kind of provide linkages to other service organizations that kind of Street Watch doesn't have the capacity to do, but also just basic stuff: food, tents, tarps, blankets, furniture, you name it. Mutual aid groups have been on the ground distributing. And I would say that in some cases that reaches as far as harm reduction supplies. So syringes, naloxone, you know, all the stuff we hand out at needle exchanges. And though those supplies are more limited, I think that certain groups have been doing a really good job at getting those supplies to people who don't necessarily always get services from the larger organizations. Whether, not that it's the org's fault, but just generally because, one, LA is huge. It's a massive city with a huge population, but also some people just don't go to larger organizations for services. And I think that for those people, these mutual aid groups that have been stepping in are kind of saying, hey, we know that you don't necessarily get your services from these other orgs, but we're out here at this time every week. If you need anything, ask us, and maybe we can help kind of link everybody together and create a broader network of support for you. And just from my own experience, being out in some of the camps near me and interacting with a lot of folks who are my neighbors, who I see every day, they've kind of been relaying that these mutual aid groups are really stepping up to the plate. And I don't want to say filling in gaps, but kind of in their own way, reinforcing some of the systems that are already there and kind of bolstering them from the ground up. And I think that, there's just, I hope that in the future, these mutual aid groups continue to do this kind of work. I think it'll just create a stronger base of support for the people that we serve.
Yeah, I agree with everything Jesse just said. And I know that we've been partnering with Services Not Sweeps. They've been a great advocacy group and have gotten a lot of momentum on setting really strong demands for simple things. There's a long list if you want to Google them. They have a great website, but just getting access to clean restrooms, and that's why we have a few more hand washing stations out there and access to showers. They've really been good at, it's really a public health strategy or approach to the work on how we address encampments versus just having client or encampment swept away. It's more about bringing services to the encampments and have a more compassionate and humane approach to the work. So they've been a really powerful group that we've partnered with. LA Canne is another one, which I'm sure most of you have heard of. We've partnered with them and had them really help with getting resources out to clients, supplies out to clients during this time, or to the community, especially in Skid Row. And I agree that with what Jesse said, these groups can really work with clients in a whole different way and start that initial engagement and building that trust that is so important in order for individuals to even entertain possibly getting support someday if that's what they choose. And then the last group I want to shout out to is SELA in the Westlake area. They've actually, raised money to provide meal cards for the clients living in the SO district. And so just with partnering with our CES team and honing into that and just providing those, again, those basic needs that sometimes we overlook are really important, especially during this time.
I was just going to say, I think, so SELA, I think, is the same thing. I think for me, it's been really fascinating to watch organizations that that wasn't their experience, right? They were dealing with a different set of kind of issues. Substance use wasn't really their focus, and having a neighborhood council come and approach us and say, hey, can we have a naloxone training, and how do we distribute that? So that's been really amazing, because kind of what Jesse said and what Amber touched on is the folks that I work with, or that we represent and we want to advocate for, unfortunately, on the most part, have kind of been marginalized from the medical model. And so it's very hard to build that trust back up. And so suddenly something happens like a COVID and it's fantastic. I think, Tobin referenced this earlier in the conversation. That's been really great is actually seeing the medical model shift a little bit and look to us for advice and changing maybe the vernacular and the conversations around it. But, we still have a lot of people that unfortunately it's going to take a long time, and it's not going to mean COVID isn't going to mean that they're suddenly going to walk in to a clinic. That's not going to change anything. They have a bigger fear of the clinic than they do of COVID. So I think that's been an interesting one, and mutual aid's been a really fantastic way to start having those conversations and letting people know, while the outreach has maybe stepped back. And I think a lot of people can also sometimes be really apprehensive about, city-led outreach because, again, they're tied into a medical home or they're tied into a government agency, and people have concerns around their data collection. So it's been a nice bridge to allow kind of for these like people to be able to get in there and have these conversations that don't feel like, I don't know, I just think for people it feels more genuine and it feels like they can connect and they don't necessarily have to have all their other fears exposed, if that makes any sense.
For sure. You know, an interesting little anecdote. I was out maybe a week ago at the camp that I live maybe 500 or 600 feet from the 405 overpass over Venice. And there's a pretty large camp under that overpass. I walk by it all the time. I think I know probably half the people there by name at this point. And I was out distributing naloxone and sat down with two of the people that live there, two of my neighbors, and we just started chatting. And I think that at a time when, as Amanda said, people, you know, they understand the risks, but might be really scared of engaging with the medical system, just being able to sit down and talk to somebody, you know, was a huge deal for them. As someone that does a lot of qualitative research where I'm interviewing people, it's, you know, I'm always trying to look out for kind of those, how somebody's feeling while they're talking. And it was very interesting to hear these folks talk to me about how mutual aid efforts are bridging kind of their community to the medical model without necessarily saying, hey, you need to go to a clinic or you need to go talk to somebody. It's more just a, hey, here's services if you want them. If you want to be connected, here's how we can connect you. And no sweat. And we've had so many people approach us and say, hey, I would love to get in contact with a therapist, or I would love to get in contact with someone who can prescribe me buprenorphine, or I'm ready to go in for treatment. And those types of people might not otherwise have ever voiced that, or might have voiced it much later. And so I think that, as Amanda said, it's almost like some of these kind of grassroots groups are advocating for people that normally might be too scared to kind of step up and voice what they really want. And I think that in terms of harm reduction, that's a huge win for all of us. That means that larger organizations can continue to provide their services to clients who they might not otherwise have seen. And that also means that clients who are living on the streets now have an opportunity that they might not have otherwise had before. And to me, that means a lot personally, but it also, I think, means a lot for the state of harm reduction generally.
So I wanted to be cognizant of the time. It's about 4:54. Time flies. I had written like 8 questions and I've asked maybe 3 of them. So I kind of wanted to get into like maybe like winding this panel down. Something that I think it's really important that we talk about, what are some best practices or guidelines we can give to people who are still using, you know, like what does not using alone look like in the middle of a pandemic? What are some things that you think that it's really important for community members to know? And then we need to pick from, and then like what are some policies or something that you really want to see taking, you know, like moving forward?
For my part, one of the things that we advise clients is that they don't lose their support network. Although they are not seeing people, you know, to make sure that whoever that is, it could be a family member, a friend, a service provider, that they keep in contact and that they keep checking in, you know. That's one of the main things that we talk to them. Also, this is kind of like open another conversation, but fentanyl still is a problem. And so one of the things that, you know, we have peer educators that we gave fentanyl test strips. And so we ask them to keep utilizing those and reach out to whenever they need some kind of assistance. I mean, we are learning as we go, right, with this new way of living, and so and providing services. And so we just for me, that's one of the main important things, is that they don't lose communication with their support network.
I can go. I think a couple of things. Just as far as like the not using alone and different supplies, like we've been giving out meth pipes and also crack pipes at our syringe exchange, and that's been hugely successful. We've given over 2,000 out, so that's something that we definitely want to keep on doing. But ironically, the funding can be a little hard to get for that, so we've been using our discretionary funds. So just being able, I guess, as a broader system issue is just getting, really understanding what the supplies are and how they're being used from a public health strategy. Not that it's just what people often think of as enabling use. That's not what we're trying to do. We're trying to keep people safe and keep people alive. So I think for the community, just being open to those ideas. And then a couple of policy related things that I think what we would love to see, and I'm going to speak on behalf of the whole panel here. So we partner, our agency works with a place called the Men's Home in Copenhagen. We have an employee immersion program there, and Copenhagen has such an amazing model. They have the safer consumption sites there. They actually operate one of the largest ones in the world, I believe. And they have, a smoking room. They do a lot of services. For all of their services focus on people who are injectors or substance users. So I think just really replicating the models that are done in other countries, and being open-minded to what safer consumption site, or I think here in the United States, we're calling them overdose prevention sites, what that really means and why it's so important, because it does save a lot of lives. Like Copenhagen has very, very minimal overdoses because they're there. They're able to respond quicker since they're, centralized. And then it also creates a sense of community for the individuals accessing the service. And then the last thing I'm going to mention is decriminalization. Like, if we're seeing so many people being released from our jails right now in our prison system, why are they there in the first place? So how do we really focus on decriminalizing, and even if it is starting out for possession and drug use, but hopefully someday it could even go beyond that, and where we're just having some type of, drugs being legalized in a different way. And I know Copenhagen also does, they kind of turn the other way. It's not completely decriminalized there, but they practice a lot of that in their open air drug scene. So I think just taking lessons learned from other countries, and we've been able to do a little bit of that here and there during this COVID environment, which has been interesting. So how do we build on that momentum?
I'll make a bit of a, Amanda, you were unmuted first.
No,
so.
Okay. I just with the overdose prevention side, I get very, very excited. Essentially, I was going to say, in terms of resources for not using alone, there's a fantastic organization called Never Use Alone. They have a national phone number. You can call them. You can give them your information. If they call back and they don't hear, you don't pick up, they can send the paramedics to your site. There's another website that's just launched. There's an app that's just launched. I haven't vetted it yet, so I don't feel comfortable necessarily, but there is kind of that same technology that's about to go live. So once I do that, I'll pass the information along to Alexis, and she could blast it out to everybody that's on the chat. I think the basic harm reduction tips are still really important. If you are housed and you have the ability to keep your door unlocked, we always kind of stick to those, right? So, and there's still ways to use substances while social distancing, doubling down on naloxone. So I think there are certain things that we can do to mitigate the risk in terms of using alone. In terms of policy, which is where I get very excited about, is ODS, right? So overdose prevention site. There's a lot of things, right? There's the syringe service sunset, kind of the bill. We don't want it to sunset out. We don't want to have to keep continually applying for new funding for syringe services. We want that to just go on. There's insurance. There's a lot of advocacy work being done around insurance costs for medication-assisted treatment, making sure that the cost is equal across the board. So whether you're publicly insured or privately insured, you're not left with exorbitant prices and costs. And then lastly, which is one I really get excited about, is contingency management. So Senator Wiener has a bill on the floor. It's SB 888, and it's around increasing the funding for contingency management, which is one of our only evidence-based practice interventions for stimulant use disorder. So that's exciting. And actually, the SAMHSA just released their next round of state funding for opioid response grants, and it actually includes stimulant use disorder. So it's not just discretion, it's just not tied to opioids. and they're allowing for us to bill out on contingency management. So there's been shifts. We just want to see it higher than $75 a person per year. So it's an exciting start, though.
Yeah, I'll make a quick policy plug for something that I think is probably a little far out for the U.S., but who knows, maybe it's attainable, and that's safe supply and safe prescription. I think that some people, it would be a life changer for a lot of people that can't get their hands on substances that they feel safe using without putting themselves at extreme amounts of risk, especially if you live in an area where there might be a lot of fentanyl contamination in other drugs. Having access to a safe prescription that you can use, that you know what's in it, would be incredible. But again, I think that's kind of a far out policy goal for the US right now, given our administration. But in terms of kind of like ground level harm reduction tips, as Amanda said, kind of the same things generally apply. I've been telling people, go slow. If you can do a tester shot, do tester shots. Obviously, if you can avoid sharing things with people, avoid sharing things with people. But the one thing that I have been hearing, and I don't know if any of our other panelists can confirm this from their own orgs or neighborhoods or clients, but I have gotten some tips that syringe resale has increased recently. Even though a lot of services have remained open and operational and kind of fully functioning, I have been hearing from some folks that in their kind of social circles or their camps, there has been a small uptick in kind of bulk and single syringe resale, as well as preloaded syringes that are being sold. And obviously, I can't advise anybody that I talk to that would be a safe thing right now. Generally, probably not a safe thing, but especially right now, not a safe thing. But unfortunately for some people, if that's their only access to a syringe that they haven't used 5 or 10 times already, people are going to do it. And I think that, if we can find ways moving forward to, at least geographically within the city, provide more service coverage, that would be incredible. But obviously that's funding dependent, and without more funding to spread out to more people, then that might not be able to occur. So, I've kind of been trying to tell people that do all the normal stuff that you do to keep yourself safe, but just be a little extra careful, especially if you're using like preloaded syringes, or if you have to buy syringes from people that you know.
I have to sign off. I have to go.
I think on that note, we're going to start to wind this down really. I have one closing slide that I'm going to share, which has got some resources on it. And again, everyone who attended, everyone who registered is going to get an email blasted out with some resources, including a naloxone guide. But here on screen, you have the Never Use Alone hotline, the California Hub and Spoke System, California Bridge program as well. Those are some links that y'all can copy down and share out and share wide. Does anyone want to do any closing remarks? Anyone want to say anything before we sign off?
I just want to thank you for letting me be part of this panel. I think it's very important to continue these conversations and to keep informed the community and other service providers as well. One of the things that I think happen constantly is that we think that everybody knows what we know, and it's not like that. Everybody has different ways of working and different type of services, and so it's always good to learn and to have an open mind to learn of what else is out there. Thank you so much.
Thanks, Roger. Anyone else?
I'll just say, just to echo Roger, I agree. Stay open-minded and don't be afraid to be different. I think it's the things and the different approaches, even though we may think it's innovative, it's really just the human thing to do. So just do the human thing.
Great.
Oh, and if you can get involved in any local organizations and you feel safe doing so, now's a great time to do it. So many organizations are taking on loads of new members, and people that can effectively work in those roles are hugely important right now. So if you can